shall we cover maybe the presentations of inflammatory arthritis? I think if you move on to the next slide, and I'll try and cover as much about the test as I possibly can. Next slide, please. So the first, I guess, of 4 presentations I would consider would be small joint polyarthralgia. So we get referred a lot of people in whom joint swelling isn't perhaps the main feature, but there's a suspicion of an inflammatory arthritis, and you can find this in people with very early inflammatory arthritis. But the kind of diagnosis I'm thinking about when you know I'm seeing someone with this referral are joint hypermobility or perhaps occupational related problems. You guys will be very familiar with many of these presentations, and there's of course the inflammatory subtype of osteoarthritis, as well as some metabolic causes, which I'll come to later on, but importantly hemochromatosis and iron overload syndrome, or even hyperparathyroidism as well. You guys will see a lot of like we do, fibromyalgia, and the key really in the history is the non-refreshing sleep aspect. But also, if I see a patient in clinic without any joint swelling, I'm also thinking about the possibility that they've had palindromic arthritis with symptom-free intervals, often for quite extended periods of time. Now, on the kind of borderline of early arthritis, but more of a connective tissue disease feature, you can see arthralgia, particularly with inflammatory features, so worse first thing in the morning or towards the second half of the night in diseases like lupus and even Sjogren's syndrome as well. And you often get other clues such as a photosensitive rash in lupus, mouth ulcers, or sicker symptoms, so dryness. Both can have a Raynaud's phenomenon as well, so and problems with their peripheral circulation, particularly in the cold. And I think it's very important not to miss systemic sclerosis, which is a fibrosing condition of the fingertips in either limited or diffuse cutaneous forms. And those patients will have a tight, waxy, hairless skin over their finger specifically, and they'll often have very specific nail fold changes and even ulceration where the blood supply is not good. Can you move on to the next slide, please? So I just put up some images. So talking about systemic sclerosis, in the bottom right, you've got a patient with both Raynaud's phenomenon and also slightly shiny tubular fingers with increased connective tissue in those fingers. And if you zoomed in close on the nail folds, you can often see some dilated blood capillaries. Top right shows the Sturm's test for Sjogren's syndrome, and in the bottom, that snowstorm appearance is an ultrasound of an X-ray of a salivary gland with some contrast injected into it. Osteoarthritis you'll all be very familiar with, and can often be associated with very good physical function. And as you guys do as well, I'm sure you see a lot of hypermobility and also fibromyalgia causing non-inflammatory symptoms. Next slide, please. Okay, so thinking about a more inflammatory picture. So the conditions that I'll be seeing most often, and this will vary from country to country, include rheumatoid arthritis, which is certainly our kind of most common inflammatory arthritis, and is a small or mixed joint polyarthritis. I'd certainly expect rheumatoid arthritis to start with a hand joint, although there is certainly variation, and you can get rheumatoid presenting with arthritis of just one large joint, such as the knee or the wrist sometimes, before going on to affect others. I think you can get rheumatoid-like arthritis without antibodies, which is very important to know, and I'll come to that later on. But there are also arthritis subtypes such as psoriatic arthritis, which are very similar to rheumatoid in their presentation, so they have a small joint arthritis affecting wrists, elbows often in addition. Systemic lupus can also have an arthritis like this, and it's becoming more obvious, I think, as these viruses spread around the world, that there are very specific viruses like chikungunya, which certainly mimic rheumatoid arthritis, but don't necessarily stay and persist and require treatment such as rheumatoid would do. Certainly in our more elderly portion of the population, we see a lot of polyarticular gout. Usually there's a clue to the diagnosis with toe-fist deposition, little bits of crystal in the skin, often over the ears or sometimes over the joints themselves. And the patient will almost always have had a very typical articular flare, and that's typically affecting a big toe. So gout, I hope, shouldn't be too easily missed. Now, one of the conditions that we see much more rarely, but is definitely worth considering in this category, is adult onset Still's disease, which is an autoinflammatory syndrome and has a very characteristic salmon pink rash, which I showed a picture of, as well as fever, very prominent lymph node swelling and abdominal pain as well. Sometimes the chest can also be affected. This isn't something we see much in the UK, but acute rheumatic fever is certainly worth thinking about in this context as well. Next slide, please. So on the top left, I'm sure you'll recognise some of the very characteristic deformities of a rheumatoid arthritis, but top right is kind of similar deformities, but completely reversible in the hands of a patient with lupus erythematosus, so connective tissue disorder, and those are principally due to damage to the tendons rather than the joints. So you wouldn't necessarily see any erosions or changes on an X-ray. And in the top middle is a typical nasolabial sparing rash on the face of a patient with lupus erythematosus. Bottom left is a very typical rheumatoid nodule seen in patients with seropositive disease, and that salmon pink rash I told you about, Still's disease, is the bottom right, and is often only present at certain times of the day, often in the evenings, and can be easily missed if you're not vigilant for it. So I think that is enough of the dry background. I would like to do a little bit of interaction with you guys and hopefully get your brains thinking. So this is not necessarily inflammatory arthritis. This is just to extend your extend your thinking caps to some other diagnoses that might come into my clinic or into your consultations as well. So 63-year-old man who's a groundsman. Next slide, please. And he presents like this. Anyone shout out or write in the chat what the diagnosis is? Excellent, yes, Dupuytren's disease, and in this case, Dupuytren's with contracture. Next slide, please. So if you have Dupuytren's disease, how can blood tests help you? So if I see a patient with Dupuytren's disease, I would be thinking definitely about occupation, but I would also be thinking, especially in the population that we look after, of alcohol consumption. And there are some clues in your routine blood test to a patient who has alcohol consumption in excess of recommended limits, particularly. And those would be a raised mean cell volume, so the red cell are increased, derangement of the liver function test, and particularly the gamma GT. And on the other side, if the liver is occupied detoxifying alcohol from the body, it may not be producing enough albumin, and it may have low platelets because of toxic damage to the bone marrow. So in a patient with very severe liver disease, they may also have a high INR, so a clotting blood test indicating decompensated liver disease. Next slide, please. So one of the things that increases your inflammation marker, specifically the ESR, can be the immunoglobulins, and patients with various types of liver disease can often have a hyperproduction or a gamma globulinemia with their as part of their presentation, and that will often show in an elevated ESR, but with a normal CRP. So when I say gamma globulinemia, the picture on the right is a protein electrophoresis strip where proteins are separated on the basis of charge and size. And gamma comes from the fact that there are alpha, beta, and gamma sections, and the gamma globulins are where All of these are, and they're all antibodies that do your memory cells, that's IgG, host defense stay in the gut and the skin, which is IgA. IgM is the acute response to infection, and IgE, or the allergic antibodies, are defense against parasites. Just summarized by saying that, I know this talk was about tests, and tests are important, but really, if I am looking at a referral, the clinical presentation is much more important. And if physio and sports medics have a super strength, it will be that your clinical assessment will be, 10, 20 times more accurate, detailed, and thorough than mine would be. Certainly than a primary care physician's is likely to be. And I think the more detail in the referral, the more help we can be. I would say that the tests are there to refine your diagnostic probability, but it's always worth thinking about, revisiting a diagnosis if when you've done the tests they don't make sense. And the other thing to say is that the more tests you request, the more very bizarre results you get. Sometimes the right sample for the wrong patient, or the lab just loses it or does something wrong, and you get a very abnormal result. If the test doesn't make any sense, consider repeating it to see if it was the test and not you. Fantastic. Thank you all for your patience. Thank you for your attention and your interactivity as well. Any questions for me at all?
Oh, thank you very much, Dr. Doig, for a wonderful presentation. You have covered all of the aspects. I'm sure that you can speak on a single aspect for whole day, but thank you very much for cutting it down and covering all the aspects. That was really, really good, and it has increased my knowledge and understanding today a lot, although I've been working in the rheumatology for the last 5 years, but this has increased my knowledge about referring. And then the idea was that we know osteoarthritis very well. We treat specific issues, specific tendons, specific injuries. But when it comes to inflammatory arthritis, especially the seronegative one, we don't have much information as a physios. So what I wanted them to have an understanding of the systematic issues, the seronegative and the seropositive side of the inflammatory arthritis, and when to make the referral, and how to identify the signs and symptoms which leading towards the systematic issue. So thank you very much. I think the time is to take some questions, and we'll see if there are any questions. So there is one patient with SI joint pain who is young, 20 to 30 years, female, no hypermobility, and in the joint, not much morning stiffness. Would you suggest it's worth to get it imaged and blood tests?
Yeah, I think, well, first of all, thank you, Amir. That's very kind of you to say. And for a patient in their 20s, I would always be thinking about hypermobility, which is perhaps one of the most common and most underdiagnosed issues. So we see a lot of patients with SI joint pain. The features that would increase your likelihood would not only be the stiffness. Unfortunately, so-called inflammatory back pain doesn't really distinguish between inflammatory and non-inflammatory causes of SI joint pain too well. And lots of patients with a very inflammatory sounding history, morning stiffness of 30 minutes an hour, can have negative MRI scans. But the features that would make it more likely would be pain in the second half of the night, buttock pain, especially alternating buttock pain, and any features outside that suggest those, seronegative spondyloarthropathy associated conditions. So inflammation of the eyes, inflammation of tendons, plantar fasciitis, epicondylitis, Achilles enthesitis. All of those would increase your clinical likelihood. I would definitely suggest doing blood tests, and you can look for inflammation, but I wouldn't allow negative blood tests to put me off imaging if there was a high enough clinical suspicion, because in a patient who is 21, you wouldn't want to delay making a diagnosis of spondyloarthropathy, which would then go on to cause increasing restriction and pain in the future. So yeah, I think the history is really the key there. Examination doesn't give you much, and the history is the key. thank you all for your patience, and thank you all for coming and staying. It's a huge audience, and you're still here at what must be very late, I guess, where you guys
It's
are.
quite late actually. In Pakistan, it's half 11 in the evening in the night, so yeah, still awake and listening to you.
I hope that most of you don't have work tomorrow anyway. That's amazing.
Yeah, or it's Saturday, so most of them will be off tomorrow. So thank you very much, Dr. Tyke.
My pleasure. Thank you, Amir. Thank you all.
Bye.